I hope you had all received the case scenarios. Hope you had the time to go through. We'll go through it side by side while we are doing the presentation. So this picture is just to trigger your curiosity. We'll see what it means towards the end. It has a relationship to the topic we are discussing today. So the structure of this presentation, over the next few minutes, we will go through the physiology of potassium handling in our body. And subsequently, with the cases given to you, we will intersperse and discuss the pathophysiology of hyper and hypokalemia in each clinical scenario and how we address it. So I want you to focus on this first picture. So the intake of potassium into human body normally is through the food, the meal that we take, and it's handled in various ways inside the body, and the excretion happens through two routes. The majority is by the kidneys and a small proportion by the colon itself. When we take a meal, regarding absorption, a large chunk of potassium absorption happens in the small intestine and excretion happens through the colon. When we look inside the cells, we see that the intracellular concentration of potassium is very, very high. About 96% of total body potassium is inside the cells. Only about 2% is in the extracellular compartment. This concentration is maintained by the system of ATPase, sodium potassium ATPase pump. And coming to the second picture, as we know, there's large amount of potassium sequestered inside the cells. Most of it is in the muscle cells. As you can see, the concentration is about 3000 milliequivalents, and some in the liver and the red blood cells, and the rest, a very small quantity in the extracellular fluid. So average dietary intake has been estimated to be about 100 milliequivalents per day. Of this homeostasis is being maintained, and the excretion of it, as I said, majority by urine, about 92 milliequivalents per day is excreted in urine, and stool is a very small quantity. So when it comes to potassium homeostasis, there are two mechanisms. The external homeostasis mechanism ensures what we take and what is excreted. An internal homeostasis mechanism maintains the intracellular and extracellular concentration appropriately. So external homeostasis mechanism has a reactive mechanism. Looking at the first picture, the picture on the top, when there is a potassium load that is taken inside, the gut itself senses how much potassium is there in that particular meal, and there are gut calorific factors which are immediately released and they mediate excretion through the kidneys. Also, when there is overflow of absorbed potassium into the bloodstream, that is sensed by the feedback mechanism, that is through the aldosterone mediated negative feedback mechanism. And also immediately the aldosterone mediated mechanism will take some time. So immediately what happens, there is potassium sequestration into the cells. So this happens whenever there's a meal driven potassium intake and the cell potassium gets sequestered, and there's a feedback mechanism to excrete and gut mediated mechanism to excrete. What happens when there is no meal intake? The sequestered potassium inside the organs slowly gets released, and then it again acts through the feedback mechanism mediated by aldosterone and gets excreted. So this is the basis behind how the plasma potassium is very tightly regulated between a very narrow range, 3.5 to 5 milliequivalents per liter. So I just want to highlight that there is a circadian rhythm which is inbuilt in the body for potassium excretion. So the white are noon and the black are nights. So during the day, especially at the noon, there is peak potassium excretion. During the night, it is low. This happens despite changing the amount of potassium that is taken by the body. Even when there is 100 millimoles of per day intake, there is a circadian rhythm to it, And when there's a large amount of potassium intake, the excretion goes up and there is a circadian rhythm to it. So why is this important for us? Because there's a circadian pattern in potassium excretion. When we do urine sampling to evaluate hypo or hyperkalemia, depending on what time of the day it is sent, the values may vary. So a spot potassium value may be unreliable. So we saw that majority of potassium is excreted by the kidneys. So just a word on renal handling, exactly where in the nephron is the potassium absorbed and excreted. So potassium is freely filtered across the glomerulus, and majority of potassium absorption happens in the proximal and the initial ascending loop of Henle and the initial part of the distal collecting tubule. It's freely absorbed. So how is it resecreted and reabsorbed? For the sake of homeostasis, is that happens at the distal collecting convoluted tubule and the collecting duct. So there are regulatory mechanisms mainly by aldosterone which act at this area of the nephron to maintain the homeostasis. So which cells in the distal convoluted tubule and collecting duct? Mainly the principal cell. So where does aldosterone act? At the epithelial sodium channels. So aldosterone acts on this and the sodium concentration is increased, and hence this pump at the distal basolateral part of the cell is able to exchange the excess potassium for the sodium, and subsequently increased potassium inside the cell exits into the urinary side of the cell through the freely open potassium channels. I'll just go through this again. The cell which I am talking about here is the principal cell. It is located in the distal part of the distal convoluted tubule and the collecting duct. This is an important cell to excrete the potassium, excess amount of potassium in the serum. So this side is the basolateral cell. This side is the apical side. So this is the urinary space. So when there is lot of potassium in the blood, that has to be exchanged into the cell through the excretion of sodium into this pump. This is the sodium potassium ATPase pump, so that it can get excreted through the potassium channels. What do we need for that? We need lot of sodium inside the cell. That is done by this epithelial sodium channel, ENaCs as they are called, and this is the channel that is upregulated by aldosterone. Clear? Anybody has a doubt? Do I need to tell again? Should I tell again? Clear? Shall I move on? This is very important because all the culmination of potassium derangement usually comes to the trouble on this area. So as I said, ASDN is nothing but aldosterone sensitive distal nephron. That's the distal part of the distal convoluted tubule and the collecting duct. So the factors that mediate it are obviously circulating level of aldosterone, the potassium serum concentration. Also, there is how much amount of sodium comes out into the urinary space, because the ENaC is triggered off by aldosterone and it has to absorb the sodium, and the flow rate. The higher the flow rate, the higher will be the sodium delivery. So, for example, when there is hyperkalemia, so the molecular mechanism. So, hyperkalemia will trigger of aldosterone, and aldosterone upregulates the ENaC channels. So sodium is absorbed and then potassium is getting excreted through the freely available potassium channels. This is how excess potassium is excreted by the kidneys. Clear? Just summarizing in this one last slide, when there is increased potassium intake, there are enteric sensors which directly do activate all these mechanisms which are still yet to be elucidated. Also, there are feedback mechanisms which come into place after the potassium gets into the bloodstream through aldosterone, and we saw the molecular mechanism, how the aldosterone causes potassium excretion. That happens in the distal part of the distal convoluted tubule and the collecting duct, and there is a circadian pattern to this. Just a word on aldosterone paradox. The question will come to us, what happens when there is hypovolemia, there is high aldosterone. So all hypovolemic patients, when the body physiology is trying to replete sodium and fluid, will they become hypokalemic? No. That happens without potassium excretion, there is salt retention and fluid retention. How is this achieved? There is angiotensin which comes into play when there is hypovolemia, which inhibits the sodium, which upregulates the sodium absorption and fluid retention from the proximal part, so that there is no increased sodium delivery to the distal area for the ENaCs to work efficiently. Whereas when there is only hyperkalemia, the ENaCs are triggered by the aldosterone. Also, the hyperkalemia makes sure that the sodium delivery is adequate to the distal part for the ENaC to work by inhibiting the sodium absorption in the proximal part of the tubule. Clear on this? This is called aldosterone paradox. So case scenario 1, I'll invite Dr. Phoenicia to summarize the case and give her thoughts on it based on the physiology that we discussed.
So basically summarizing, the 11-year-old boy presented with sudden onset paralysis of both lower limbs and upper limbs. So the sudden onset paralysis, the past history of similar episodes happening 3 to 4 times per year, and on evaluation also, his on examination also the same findings were confirmed, and when the investigations are done, he had a very low serum potassium level of 1.6 millimoles per liter, and she was given peroral correction, for which she was not responding, followed by which she was given an IV correction, and followed by the intravenous correction, his strength improved and the potassium levels were potassium, as the potassium levels increased, his strength was the power also improved, and he was evaluated for the other causes also, which could probably cause a transcellular shift like hypothyroidism, for which his T3 and FTC levels were all normal. So this is looking more like a hypokalemic periodic paralysis, and the cause for it is the absolute potassium deficiency, because the factors which could cause a probable transcellular shift, like an administration of insulin or a beta agonist or a hypothyroid state, is not there.
Okay, thank you for summarizing it. So we will take a relook at it. There are few things. So Phoenicia concluded saying that there is an absolute potassium deficiency and it is not a transcellular shift. So I'm going to explain to you a few things. So when you look at the patient, when there's a with so it is episodic. So this child has been well. The child is sorry, child, because it's 11-year-old. So the same, they present little early hypokalemic periodic paralysis. So the patient has been well between the periods of paralysis. He's well. There's no fatigue or myalgia between the episodes, and it's isolated episodes. And it happens at usually early mornings when he's waking up from his sleep. So it's episodic, and there are some precipitating factors. And the other thing is what happens to his penultimate value of potassium in the hospital itself. Yeah, it increases. So when there is a transcellular shift of potassium, this is how it will happen. There will be some sort of precipitating factors like exercise, stress, which will cause increased sympathetic activity, beta adrenergic activity, or when you're giving a beta agonist like a salbutamol nebulization, or when there is insulin, or in a clinical scenario, somebody would have had a soft drink or something like a glucose load, which can take the potassium into the cell. So in this particular patient, usually after sleep, because early morning the sympathetic tone is high, so that is when the intracellular shift happens, and it's episodic, and we need to watch for that rebound hyperkalemia which this patient has, because when you keep giving potassium, when the shift resolves by itself, when there is extrusion of potassium from the cells, once the beta tone is gone, they will actually develop a rebound hyperkalemia. So this patient actually has a transcellular shift of potassium, not really absolute potassium deficiency in his body. So it will be episodic. In between episodes, they'll be absolutely normal. They'll have normal potassium values, as opposed to we'll be seeing the next case where there are abnormal values even between the episodes. And definitely they'll have precipitating factors to which cause the intracellular shift, which we need to watch for. And when we're treating these patients, you cannot discharge them without monitoring them for resolution after full periodic paralysis resolution and a normal potassium value. You need to watch them for the next 24 to 48 hours because they will have rebound hyperkalemia, which can become life-threatening also. So this is what we talked about, intracellular shift. So one thing I put up this table, I just wanted to highlight on thyrotoxicosis. This is one scenario which we may come across in our wards. When somebody has hypokalemic periodic paralysis, we need to watch for thyrotoxic symptoms because that also acts through beta sympathetic stimulation to cause a transcellular hypokalemia. So we just saw the transient cell shift, and case 2 is the straight opposite of this particular case which we discussed now. Aluri, go through it.
Presenting a 32-year-old man, I presented for the first time with persistent hypokalemia, no prior medical episodes. In ED, he was noted to have a potassium of 1.8, and he's been corrected, but the potassium level has not risen. It was a maximum from 2.5 to 2.7. So further evaluation, he never had symptoms prior to this. His blood pressure was 108 by 72, pulse was 16 beats per minute and regular. So muscular man. In the other electrolytes, sodium was 141, potassium was 2.8, chloride was 95, bicarb was 31. He had a 0.7 with the urea of 14. Glucose was 92, calcium was 9.2, phosphorus was 4.6. Magnesium was 1. Other investigations usually ultrasounds of kidney were normal, but you can normal. So it was put on potassium and magnesium diet, and after this final diagnosis was relatively legitimate symptom. It started with amyloid privately, but it's final lack of the range of potassium increased up to 3.1 to 3.1. But with side effects, we discontinued the medications. The patient was followed up for more than 25 years with normal plasma potassium level 2.9 to 3.2.
So what is contrasting to the previous case scenario in this patient?
It's quite functional without low, so not low potassium.
Yeah, he's got a low potassium and he's functional and it is persistent. Always the potassium values on the lower side. Other things? How easy was it to bring up his potassium? Very difficult. And they have to add some drugs to do it. Whereas in the previous patient, he actually had a rebound hyperkalemia. So when there is an absolute potassium deficiency in the body, because we know the maximum concentration is intracellular, so the body will keep compensating by putting the potassium into the bloodstream. When they are so low potassium, it means that they have lost so much potassium. The intracellular stores are depleted. The blood potassium value is so low. So there's so much deficiency. And when you keep giving them potassium supplements, it's difficult to correct it because there's ongoing loss which we need to address, and the potassium has to get repleted to fill the intracellular and the extracellular compartment. So this tells us that there's a definite potassium loss as against a cellular shift. So when there's sustained hypokalemia, it is due to a potassium loss. So how does the potassium get lost in the kidneys? So there should be a primary increase in distal sodium delivery, because that's what we saw as the physiological mechanism underlying, or there can be a primary increase in the mineralocorticoid activity itself, like increased aldosterone. So Why is this important? Because backtracking our steps, when you clinically see the patient, you want to know which two of these category are they going to fit into. Increased distal sodium delivery happens when they are hypovolemic, when somebody is vomiting, somebody is having diarrhea, there's a lot of loss. And when there is, or is it an increased hyperaldosteronic state? Like that will cause the patient to have clinically have hypertension. So these are important clinical corroborating features which we would actively look for. So how do we establish a renal potassium loss? So we know that potassium gets secreted in a circadian pattern. So the best is to do a 24-hour urinary potassium collection. So what is the cutoff? A value which is less than 30 milliequivalents per 24 hours is normal. When there's hypokalemia, if the kidney is trying to conserve, so one small difference is when there is low sodium in the body, the renal mechanisms are so efficient that there can be zero excretion of sodium in the urine. Whereas in potassium, even with very, very low levels of potassium, the kidney cannot make the potassium excretion zero. So that is why we have this cutoff of 30 milliequivalents per day. There will be a minimum excretion of potassium always, no matter how low the potassium inside the body is. So 30 is the cutoff. If it is more than 30, then we call it as an inappropriate excess potassium loss through the kidneys. So if that is difficult and we are doing a spot urine concentration, we take a cutoff of 15 milliequivalents per liter. So doing a spot is unreliable. Doing a 24-hour collection is difficult. Is there anything else? We can do a urine potassium creatinine ratio because creatinine excretion is maintained at a constant rate. So the cutoff value for that is 30 milliequivalents of potassium per gram of creatinine. So once you establish a urinary potassium loss, saying that, say the urine potassium creatinine ratio is more than 30 milliequivalents per gram, what next do we do? Clinically assess the blood pressure. If the patient has high blood pressures, we are looking at hyperaldosteronic state, which may be because of increased renin causing increased aldosterone, or primarily an increase in aldosterone, or both being low where there are metabolites corresponding to a hyperaldosterone function which are in the blood. If the blood pressures are not normal, when the patient is not a hypertensive, then the second thing to look at is the plasma bicarbonate. When there is low plasma bicarbonate, showing that there is an acidosis, we are looking at some form of a renal tubular acidosis related diseases. If the plasma bicarb is high, then we look at the urine chloride excretion. If the chloride excretion is very high in the urine, most likely cause would be diuretics or a Gittelman or Bartter syndrome. If the urine chloride excretion is not high, then we have to search for other causes, including drugs like piperacillin, which by itself can cause caliuresis. So this is the algorithm we need to follow after establishing a urinary potassium inappropriate loss. So third case scenario, when it is not the kidneys if losing the potassium, where else can it get lost from? Civil engineering. Just summarize it. No need to read the whole thing. Just summarize in 1 or 2 lines.
A woman, 58 years old, presented with established hypokalemia. She was evaluated outside the physician and found to have a potassium of 2 milligrams and referred for further treatment and evaluation. In the past 3 years back, she had episodes of intermittent hypokalemia. Further details, lab values are not given. Then, at the present condition, she has only fatigue, no other complaints. And she denied taking any other drugs or any other precipitating factors for hypokalemia. So we evaluated her with lab values that showed hypokalemia. We checked for the persistence of the hypokalemia. Second value also had hypokalemia. So we want to find out from where the losses, whether from renal or extrarenal. So we went with the urinary potassium excretion for 24 hours. In the first 24 hours, she received both oral and IV potassium correction. At that time, the urinary potassium excretion was 12 milligrams.
Which is appropriate or inappropriate? appropriate. So is it the kidneys or not? It's not the kidneys.
In this next 24 hours also, we observed the urine potassium condition. Subsequent doses were given, and the excretion amount was also increased to 42 milligrams, and the serum levels also raised. So renal is not the
cause.
We want to look for the extra renal. So in this case, there is a use of laxatives.
So they went back and asked the patient, and then the patient disclosed saying that I was abusing laxatives. So thank you, Siranjan. So apart from renal loss, there can be gastrointestinal losses when the patient has chronic diarrhea or chronic laxative abuse, or there's a bowel diversion and there's a high output. Other things are rare. Also, we need to actively look for patients who are on diuretics, loop diuretics and thiazides. So that much about hypokalemia. So just one last case on hypokalemia. Before we go there, we'll just take a break, and some of the ECG changes of hypokalemia we need to be aware of. So the earliest change is a flattening of the T waves. The other changes emerge progressively. There can be ST depression. There can be U waves, which are the positive waves following the T waves. In severe hypokalemia, when the levels drop to less than 2 milliequivalents per liter, there can be PR prolongation. Subsequently, they can develop arrhythmias, higher degree AV blocks. So I'll request Dr. Kripa to go through the case. Just summarize it. Just summarize.
Presented with nausea, vomiting, muscle weakness. There is no history.
What's the diagnosis in that? No, diagnosis.
Hypokalemia. She is like diagnosed. Lab values, potassium was at 1.6 millimole per liter, and there was nephrocalcinosis. Those are the other diagnoses that was there. She was treated with IV potassium and 5% glucose. So the muscle weakness, which was initially 3/5, actually dropped to 1/5, and she was requiring ICU care. During that time, the replacement again was continued with potassium in normal saline. Once that was done, the potassium value started increasing.
So what's the learning point? Why did her potassium drop? It was, they were giving potassium, right? So why did it reduce further and she became even weaker? Why did it drop from 1.6 to 1.2 after giving some potassium IV? Why did it drop? Sorry? So the solution that they used to give the potassium was 5% glucose. So as we saw earlier, glucose load is one of the reasons to push the potassium inside the cell, and that caused further drop and she became dangerously hypokalemic. So this is something we should not do. How not to correct potassium? Anybody has hypokalemia, never use dextrose containing solutions to correct the potassium. You need to tell your interns at first shot before they go for writing the potassium correction order. So that's how not to correct. So how to correct? So how much, how fast? So usually you can give oral correction. If oral correction for any reason is not possible, or if the patient has severe manifestations, already patient has cardiac arrhythmias, there's a respiratory paralysis or severe rhabdomyolysis, these are the situations where we would want to give intravenous potassium correction, but the concentration of the solution should not be more than 40 milliequivalents per liter, and you should not correct by giving more than 20 milliequivalents per liter. How does it, why is it important? This is little more than what I can explain now. So the ratio between how much potassium is inside the cell and outside the cell is important for the depolarization, repolarization to happen. So if you give, don't read it, I'll just tell it to you. So when you give lot of potassium, the first potassium is going to go and sit in the extracellular compartment in the bloodstream. Slowly is when it will get taken into the intracellular compartment. So we know that in severe hypokalemia, the intracellular compartment is already low. So you're trying to replete it. So you need to replete it slowly so that there's some repletion happening inside as you give. So if you suddenly give a large load and the extracellular compartment has got a really high potassium compared to the intracellular compartment, it will lead to cardiac stunning. There will be cardiac asystole, and that is the reason why we shouldn't give a higher concentration over a shorter period of time. It should be a slow correction over a prolonged period of time. So how much and how fast can we give? So 0.75 milliequivalents per kg over 1 or 2 hours will raise it by 1 to 1.5 milliequivalent per liter. So this will distribute the KI/KE very slowly. Okay, this is the maximum you can try to replenish by. So we write in terms of grams. So 13 milliequivalents is equal to 1 gram. This is in 5 ml of syrup, and our potassium vials also are in grams. So 13 milliequivalents is 1 gram. That's all you need to remember. So if you're giving 3.5 grams, it means 13 into 3.5 milliequivalents is how much you are putting in that bottle of normal saline. So you can give only 20 milliequivalents per hour. So if you have put say for keeping calculation simple, say 1.5 gram correction you're writing, that has 20 milliequivalents. So if you have 1.5 grams, you can give it over 1 hour. So if you're giving 3.5 grams, it has to go over at least 4 hours. Okay, that's why we give an arbitrary correction 3.5 grams and 1.10 as over 4 hours. Okay, if you're putting 3 grams. Or 4 point, if you're raising it to 4.5, then 6 hours. It has to be prolonged. So if you are replacing it at an even higher rate by securing a central line and all that, ECG monitoring is mandatory, but that's very, I mean, once the cardiac asystole happens, there's nothing you can do about it. So prevention is what we need to target here. So you're trying to correct and the potassium doesn't increase. What should you troubleshoot? Check the magnesium. Magnesium being low can cause potassium loss. So through the kidneys itself. So always check for magnesium and you correct it simultaneously. And check on the infusing vehicle fluid, whether it is dextrose. So you need to change to normal saline. So case 5, we have come to the end of hypokalemia. So any doubts?
Rhabdomyolysis are giving potassium, it increases.
Rhabdomyolysis can happen as a complication of hypokalemia. And when rhabdomyolysis happens, because it's very high, 3000 milliequivalents inside the muscle cell. So when there's rhabdomyolysis, there will be hyperkalemia because of spillage. So you're asking?
To be correct, because in the previous, I think 2 slides ago, it was written for rhabdomyolysis, higher rates of potassium correction.
So when a patient with hypokalemia develops rhabdomyolysis and the potassium at that point is low, you need to consider IV correction to prevent further rhabdomyolysis. But when the index event is a rhabdomyolysis and they are having hyperkalemia, then you need to address that. Tell me.
And before evaluating, we have started correcting the Hypokalemia because it's Hypokalemia. So we need to evaluate whichever patients are having Hypokalemia, or we don't need to evaluate.
We have to evaluate. Evaluate in the sense to send urine potassium. Is that what you're asking? Okay. So it's dependent on the clinical scenario. Like if you have a patient, I think that is case 5. Am I right? Rizwana, is that your case 5 is yours, no?
Depends on how sick the patient is. If the patient is very sick, potassium is please correct from the.
He is saying we'll correct, but which all patients will we evaluate? Do you evaluate all? He is asking now. So evaluation is based, if you have enough clinical reasons there itself to explain the hypokalemia, like she's going to tell, that's the next patient. If you have enough reasons to explain it, then you don't have to send the urine potassium, everything. But if you don't have a reason, it's unexplained, it has to be one of these 4 reasons. No, there must be a transcellular shift, which is what you would see that case she's coming to, or there must be a renal loss or a GI loss, or there are drugs which are causing again renal loss. So if you don't find any of these causes obvious, then you go through the algorithm of renal loss. That is after establishing its renal loss. Other things will be evident clinically. So the profile of the patient is what will tell you what the hypokalemia is because of.
During ECG of hypokalemia, is it the PR prolongation? Hyperkalemia, there is very not location PR prolongation.
Hypo also can cause PR prolongation. Rizwana, can you summarize the case scenario 5?
So the 36-year-old woman who came with nausea and vomiting for 3 days with previous history of polyuria and paralysis previously. Lab investigation showed blood pressure like in the supine vision is 110/70, but in the sitting vision is 90/65, and the blood hyponatremia 122 and hyperkalemia. Potassium was 6.4, chloride of 85 and 84, and bicarb was 10. And annual gap of 30, which clearly indicates a high annual gap metabolic acidosis with the glucose levels of 8, 10, and urine nitrogen of 46, creatinine of 2.1, and the pH was 7.16. So diagnosis of DKA was made. The patient was treated with insulin and isotonic solution. 1 day after the treatment, her potassium reduced 2.9 and sodium was 133 with a bicarb of 16. So what is true regarding the hypokalemia on admission? The options given that total body potassium content was normal. Option B was total body stores are low due to osmotic diuresis, but the plasma potassium concentration is increased due to insulin deficiency. And the third option was total potassium content is low due to osmotic diuresis, but the plasma concentration is increased because of cell shift due to metabolic acidosis. And D's total body potassium content is high due to volume contraction and concomitant polyuria. I chose this one option C now because the potassium content is low, but at the same time, because of the cellular shift, there is hypokalemia. During acidemia, there is a potassium exchange between.
Okay, thank you. So I'll just, everybody understood the case scenario, right? So the first part of it, is there a absolute potassium deficit or not? Okay, how many for yes and how many for no? Patient has DKA, dehydrated, that's pre-renal AKI, and the potassium is high. So is there absolute potassium deficit or not? Okay. So I'll just go through the next couple of slides and then we'll come back to this particular case. Okay. So hyperkalemia again can happen because of transcellular shifts. So the second part of it was there was a transcellular shift because there was hyperkalemia initially and then it became hypokalemia. So it's general thought. We understand that we gave insulin and then the potassium went inside. But Rizwana told that there was acidosis and then there was hyperkalemia. So there's a difference between the types of acidosis. Normally we think that any acidosis will cause hyperkalemia by transcellular shift. That is not true because organic acidosis, like a ketoacidosis, will not cause a change in plasma potassium. So the patient in question, that patient with DKA, did not have hyperkalemia initially because of a transcellular shift secondary to acidosis. He had a transcellular shift because of insulin deficiency. So when the insulin was administered for the treatment of DKA, the potassium levels dropped. So whereas mineral acidosis means the hyperchloremic acidosis. So those kind of acidosis, this is the mechanism why it happens. So essentially the sodium inside the cell gets exchanged and that makes it difficult for the sodium potassium ATPase pump to get the potassium inside. So they become hyperkalemic, the hyperchloremic acidosis. Whereas ketoacidosis does not cause that. The acid is sequestered in the cell by other mechanisms which do not affect sodium and this pump doesn't get affected. Okay. So that's why in this patient, the first shot we'll think, okay, patient is acidotic, the hyperkalemia is because of that. That's not it. Anyways, it doesn't change the management. but insulin deficiency is the cause. But the second part of it will change your management. Is there absolute potassium deficiency or not? There is, because when there is diabetic ketoacidosis, there is osmotic diuresis. So there's a lot of potassium loss through the kidneys. Patient will be potassium depleted. So we have to give potassium for those patients. That is very important. Decay is a very common scenario. Patients will be hypokalemic secondary to absolute potassium deficiency. Okay, we have to give potassium. So hyperkalemia, so one part is cellular shifts. So other causes of hyperkalemia, when the renal potassium excretion is impaired, that's the main area of regulation that we discussed earlier. So somebody may ask me a question, does excessive potassium intake cause hyperkalemia? When the kidneys are functioning normally, it will not cause. If there is a renal impairment, it can cause. Also, before going into evaluation of hyperkalemia, we need to make sure that it is not a pseudo hyperkalemia, because sometimes if patients have very high cell counts, like very high platelet count or very high white cell count, these cells can break down while waiting in the lab to be analyzed, and the serum potassium may be falsely elevated. Also, even the collection methods, when there's been a lot of difficulty in collecting the sample, if there was a tight tourniquet, all those things can cause the intracellular fluid to get into the needle, and then they can also have false hyperkalemia. So these two things we have to watch out. And as just what changes can happen in hyperkalemia, there will be tall T waves, very tall peaked T waves. This can also cause wide PR and QRS prolongation. Very severe hyperkalemia can cause sine wave pattern, and asystole and VFib can happen. So the last case scenario,
He is a good case of hypertension, diabetes mellitus, and stage CKD. And he also using painkiller NSAIDs for the right knee osteoarthritis for the past 6 weeks. Now, his routine medications are hydrochlorothiazide, losartan, metformin, and the pravastatin. On examination base, vitals are stable, and we accept trace bilateral period edema. And systemic examinations are normal. And the laboratory examination showed potassium abnormalities are potassium 5.3, and bicarb is 18, and the glucose is high, and creatinine is also progressed. So creatinine is 2.8. So here my diagnosis is now the patient progressed from the stage 3 CKD to stage 4 CKD because the creatinine is 2.8. And in impaired kidney, the losartan is not available after stage 3 CKD. So it is a losartan induced hyperkalemia, and metformin also is not available after stage 3 CKD. So I will change the losartan to any cilnidipine because there is a proteinuria. So I will change the losartan to cilnidipine, and the metformin I will change either to insulin or sulfonylureas.
Anybody else wants to do anything else? See, he was a stable patient with 15 years on those medications, no? So losartan was given for his proteinuria. It helps halting proteinuria, and that previously did not cause the hyperkalemia. So he's been on a stable low dose losartan. So that is not an issue. And yeah. So anything else? What made him suddenly worse? There's a hyperkalemia which is new, no? Why he suddenly developed hyperkalemia? Any other drugs are there? Yeah, ibuprofen. So there are drugs which can cause the renal mechanisms to fail, which can add to the problems. So this patient was prescribed ibuprofen, so that causes afferent arteriolar vasoconstriction, and subsequently the flow is reduced and causes hyperkalemia. So we need to watch out for the drugs which can interfere with the renal potassium excretion. So there are many drugs. So NSAIDs, beta blockers, ACE inhibitors and ARBs are well known to us, and aldosterone receptor blockers like spironolactone, and sodium, this ENaC channel blockers, amiloride. So these are the drugs we need to be aware of to look in the prescription of patients who present with hyperkalemia. So when there is hyperkalemia, how do you manage the patient? So when it's mild hyperkalemia, you look for the list of these drugs, look at underlying renal status, look at the potassium in the amount of food that the patient is taking, and sort that out. When there's very severe hyperkalemia, ECG changes are there, then we have to act immediately. There's a table which summarizes it. So first thing is to protect the myocardium from going into arrhythmias and asystole. So there are three things which we use. We use calcium gluconate, the rule of 10 ml and of 10% calcium gluconate, give it over 10 minutes, and you can repeat it every 10 minutes. And insulin, as we know, it would shift potassium into the cells. So 100 ml of 50% dextrose with 10 units of actrapid, any short-acting insulin, it has to be given over 30 minutes. Recheck the potassium after 30 minutes to see if it has reduced. You can also give beta agonists like salbutamol, nebulize it over 15 minutes, and you can keep repeating all these measures every 15 minutes. So this is just a stopgap measure. You're trying to immediately clear the potassium from the serum by shifting it into the cells. We need to get it out of the system. So elimination measures, we can use a loop diuretic like furosemide intravenously. This is provided the patient's kidneys are functioning and the patient can excrete the potassium. We can also use the gut elimination by giving potassium binding resins orally. And soda bicarb also has got kaliuresis. So intravenously, we can start soda bicarb infusion. However, if the kidneys are not able to excrete the potassium, like in case of advanced renal disease with severe hyperkalemia, we will have to start dialysis. So these are measures which you would do for an inpatient. On OPD basis, how would you prescribe a low potassium diet? So there's something called leaching. Leaching is removing something from inside by putting more water to it. So there are steps. Basic funda is you remove the skin, cut the vegetables into small pieces, soak in large volume of water so that there is potassium extrusion. Important thing, discard that water, not to cook in the same water. Discard the water. They can repeat the process 2-3 times. And even while cooking, they have to cook in large amount of water. Discard the water and then use the vegetables. So there are foods which are very, very rich in potassium. Commonly fruits we tell them to avoid. What fruits? Specifically bananas, cantaloupes or melons, musk melons, and oranges. These are very rich in potassium, which are commonly available to our area of patients. So we need to warn them about the potassium content of this food. And tomatoes, we can tell them to cut down on the tomatoes, and these anyways they won't take. The bakery items are not recommended because chocolate and molasses are used in all the cookies, sweetening for cookies and biscuits. So those also will have high potassium. Also, when we advise our CKD patients to take a low salt diet, very common mistake that they can end up doing is get salts which are less in sodium, but caution is that they will be rich in potassium. The alternate sea salts are rich in potassium, which may tilt the balance for them with regards to potassium. So we need to check which kind of salt they are using. It can be just, we would normally say best is to use the regular table salt, but at a smaller quantity rather than using other salts. Any doubts so far? So what is this? So this is the potassium, the word no, potash. It came from pot ash. This was the pot. So potassium is a fertilizer for soil. So they used to manufacture potassium and put it in the field. So in olden days, how they did is they used to take all the woods, burnt woods, take the ashes, put it in this large iron pot, put lot of water in it. They leach the potassium from the ashes, like how we leach from it, and allow it, heat it, allow it to evaporate under the sun. There will be sediment of potassium inside this. They'll scrape it and put it in the soil as fertilizer. So that's why Sir Humphrey, when he discovered isolated potassium, named it as potassium. That's all. Thank you. Any doubts? Yeah, Tony. Yeah.
I mean, hypokalemia. Since we have seen potassium 13 milliequivalents, 1 gram we can use over 20.
In height, you are asking how fast to correct.
How fast
So
to
1 gram is 13 milliequivalents. So usually we write 1.5 grams, 3 grams, or 4.5 grams. So 1.5 gram is 20 milliequivalents that can be given over 1 hour. So if you have severe hypokalemia, you can give that 1.5 gram over 1 hour with cardiac monitoring through a central line.
The peripheral line.
Peripheral line, you'll have to dilute it further. But somebody with a severe hypokalemia, when you want to give high concentration, it'll cause thrombophlebitis. That's the only reason when we are giving concentrated potassium solutions, we would prefer a central line. And the tip of the central line should be sitting little above the atrium because we don't want to put it directly into the heart. So we need to check the X-ray, make sure it's not sitting in the right atrium. Peripheral line, it's not that you should not give, it has to be diluted in a large volume and then you can give it to prevent thrombophlebitis.
Dilute 1.5 grams at least in 500 the weight will go with that one infusion. So you can't continue your 20 milliliters per hour in the 100 ml after that 1 hour. So that's the strategy.
Anything to add?
I think ECG changes Dr. Esther said actually they correlate quite well with hypokalemia. So in case you're not able to do hourly potassium check values back, you can actually continuously look at the ECGs to see like how your patient is progressing. Second thing I want to say is about DKA. So in DKA, even if the potassium is 5.5, they'll have potassium deficiency. Only if it's above 5.5, you consider they actually have hyperkalemia. So the cutoff for correcting potassium in your DKA protocols is actually less than 5.5 and less. So you should be aware of all this correct potential. And it's a very important electrolyte. So you should correction and management is important. And you do not, if they have a correct or known cause, like they have a diarrhea and they have hypokalemia, then you do not work out. Your patients who do not, who have a hypokalemia which is out of proportion to the diarrhea or the potassium loss, then you start working on the protocol and see why they have developed the hypokalemia as the way to do it. So the only things I want. Look at the ECG, look for changes, and yes, PR interval is prolonged in hypokalemia. To answer your question, and also absolute potassium deficiency exists in the patient. Keep that in mind.